Thank you for joining me today. In this video, we are going to learn more about pregnancy and lactation in psychiatric, how psychiatric illness affected the mother, and lactation stage. We are going to learn how to perform a comprehensive psychiatric assessment during the pregnancy and the postpartum period. We are going to explain psychiatric changes that affect psychotropic medication, pharmacokinetics, how the drug moves in the body when the mother is pregnant. We are going to recognize a common and severe psychiatric disorders during the pregnancy. We are going to differentiate normal emotional changes from psychiatric illness during the pregnancy. We are going to select evidence-based treatment that balances mother and fetal risk. We are going to consult a patient regarding the breastfeeding while taking a psychiatric medication. How do the psychiatric medication that the mother is taking affects the fetus? We are going to develop a treatment plan using a shared decision making with the patients. We are going to recognize psychiatric emergency during pregnancy and lactation phase. Psychiatric and lactation are among most important in psychiatric assessment. They are important because maternal mental health. It's important because of the fetal development. It's important because of the neonatal adaptation, medication safety, breastfeeding compatibility, relapse prevention. One of the most important principles is untreated psychiatric illness often carries great risks than appropriately selected psychiatric medications. For example of a risk associated with untreated illness includes suicidal ideation, poor perinatal care, substance usage, malnourishment, preterm birth, low birth weight, impaired mother and fetus bond, increased risk of a postpartum depression and psychiatric illness. Physiology changes that happen in the pregnancy affects a clinical, it has a clinical effect. Physiology changes that happen to pregnancy in pregnancy has a clinical effect. Increased blood volume lowers the medication concentration. For example, if the patient is taking psychiatric medications and they are pregnant, pregnancy increases the plasma volume and that lowers the medication concentration. Increased cardiac output faster distributes the medication. Increased renal blood flow increases the renal clearance of the medications. Increased kidney filtration faster eliminates the lithium. If the patient is taking lithium, it will eliminate that quickly, and other renal clearance medications. Increase the hepatic metabolism selected enzymes. Increases the metabolism of some of the psychiatric medications. Decrease the albumin, which is the protein that binds to the medication. Decrease the albumin leads to higher free drug fracture. Delay gastric emptying that happens when the mother is pregnant slows the absorption of the medication. Clinical implication: many patients require dose adjustment, especially during the second and trimester in the pregnancy, followed by dose reduction after the delivery, as a psychiatric returns as a physiology returns to the baseline. Psychiatric disorders that are commonly evaluated when the mother is pregnant include the depression disorder. Factors include previously depression. If the mother had a depression previously, she will be more risky to have when she is pregnant. Previous postpartum depression, those are the risk factors. Previous depression, previous postpartum depression, family history of depression, intimate partner violence can increase the depression. Poor social support can increase the depression. And planned pregnancy can increase the depression. Financial stress can increase the depression in the pregnant mother. Medical complication can increase the depression in pregnant mother. Symptoms are identified to those outside the pregnancy, but may overlap with the normal pregnancy changes, like fatigue, sleep disturbance, appetite changes, and carefully assess is essential. Anxiety disorder can happen when the mother can feel the anxiety disorder when she is pregnant. Commonly, disorders include generalized anxiety disorder, panic disorder, OCD, social anxiety, specific phobia. All these psychiatric illness can get worse when the mother is pregnant. And treat anxiety is associated with hypertension, poor perinatal care, increased substance usage, increased C-section delivery, premature delivery, bipolar disorder. This is one of the highest risk diagnosed during pregnancy. So bipolar disorder is one of the highest risky diagnosed during the pregnancy. Discontinuation of the mood stabilizer markedly increases the relapse risk. Mania, depression, mixed episode can happen during the pregnancy and postpartum. Patients with bipolar disorder require closely monitoring during pregnancy and especially after delivery. Schizophrenia risk include medication non-compliant, psychiatric relapses. If the patient has schizophrenia, they can have medication, they have a risk of medication non-compliant. Some people stop the medication because they are pregnant and they don't want to hurt their child, or they are going through stress, other stresses. Psychiatric relapse is increased when the mother is pregnant. Poor perinatal care is happen when the mother is pregnant and having a schizophrenia diagnosis. Homelessness increases, substance usage increases when the mother is schizophrenia and is pregnant. Obstetric complications increases with pregnancy. Continuation of effective psychiatric therapy is often appropriate after individualized risk-benefit assessment. OCD symptoms frequently get worse during the pregnancy and immediate after postpartum. Intrusive thoughts of harming the fetus, harming the infant happens. There are typical ego dystonic and different form of psychosis because inside is preserved and thoughts are unwanted. Psychiatric emergencies that happen when the mother is pregnant include suicidal ideation. Always assess the ideation, intent, plan, mean, protective factors such as what is preventing you doing this and what is the protective factors that help the mother to cope. Previous attempt, you want to assess the previous attempt. Maternal suicidal remains the leading cause of pregnancy associated mortality in many settings. Psychosis when the mother is pregnant. Psychosis, new onset psychosis during the pregnancy or postpartum requires immediate evaluation. Possible causes are bipolar disorder, schizophrenia, medical illness, substance intoxication, neurological disorders. Catatonia may occur with mood disorder, schizophrenia, medical illness requires urgent recognition and treatment. Principle of a medication management when the mother is pregnant include treatment decision making should consider a severity of the illness, previous treatment response, history of a relapse after medication is discontinued, gestational age, because the medication could affect the fetus and depends on gestation age of the fetus. Fetal risk, you want to assist the fetal risk, you want to assist the gestation age, you want to assist the maternal risks for this medication, you want to assist the breastfeeding plan and patient preference. Avoid discontinuation of a psychotropic medication solely because of the mother is pregnant. You have to consider all this that we talked about and you have to assist them. Antidepressant medications, SSRIs, generally considered a first-line pharmacotherapy for moderate to severe depression and anxiety disorder during the pregnancy. So SSRIs are the first line of treatment for depression and anxiety for during the pregnancy and when the medication is indicated. Common examples include Zoloft, Abilify, fluoxetine, and citalopram. Potential neonatal effects after a late pregnancy exposure include transient poor adaptation, systemic such as tiredness, respiratory distress, irritability. The fetus will be like that. Fetus will feel tiredness, respiratory distress, irritability, feeding difficulty, low blood sugar. These symptoms are usually self-limited. SNRIs medication like venlafaxine and duloxetine used when the clinically indicated, particularly if the previously effective. Monitor mother blood pressure because this medication may contribute hypertension. Pregnant mother already has hypertension. Pregnant mother who already have a hypertension, these medications might also increase the hypertension. So when you prescribe this medication, you have to assist the blood pressure. Bupropion may be used for depression and smoke cessation. Avoid in the patient with a significant seizure risk or other eating disorders. Mood stabilizer like the lithium, highly effective for bipolar disorder, and important consideration are cross the placenta. So lithium crosses the placenta and that affected the fetus. Also, you want to also consider blood concentration decreases during the pregnancy due to increased renal clearance. So lithium Lithium concentration decreases when the mother is pregnant because of the increased renal clearance. Concentration rises rapidly after the delivery as the renal clearance normalizes. Frequency blood monitoring is required during the pregnancy and postpartum. Monitor the renal function and thyroid function for lithium. Lamotrigine, often preferred for bipolar depression, pregnancy markedly increases the clearance, so serum concentration may be fall substantial. Dose adjustments are often necessary during the pregnancy with reduced after delivery to avoid toxicity. Fulbright. Fulbright should generally be avoided during the pregnancy because of the neural tube defects, neurodevelopmental effect, congenital malformation. So Fulbright is not indicated for pregnancy because it can affect the fetus. It can affect the fetus development, fetus it causes neurotube defect, cognitive impairment, neurodevelopmental effect for the fetus, congenital abnormality, carbamazepine is associated with increased risk of congenital abnormality and neurotube defect. Alternative treatments are generally preferable during the pregnancy. Antipsychiatric medication, second generation, are the commonly used when clinically indicated. An example of a second generation antipsychiatric that can be used when the mother is pregnant include Seroquel, olanzapine, Risperdal, aripiprazole. However, you have to monitor the weight gain, glucose blood sugar checks, lipid assessment, blood pressure, because they increase the weight, glucose, lipids, blood pressure. Patient remains at increased risk for gestation, diabetic, and metabolic complications. Gestation diabetic, and metabolic complications. Those are the risks you want to assess. Benzodiazepine refers for situation where the benefit outweighs. Benzodiazepine is reserved for situation where the benefit outweighs the risk. Potential concerns include neoneural sedation, so the fetal will be sedated because mother is taking the benzodiazepine, respiratory depression for the fetus, withdrawal symptoms with prolonged exposure to near delivery. Use the lowest effective dose for the shortest necessary duration. Use the lowest effect. Benzodiazepine, use the lowest effect dose for the shortest necessary duration. Breastfeeding and lactation. Most psychiatric medication are transferred into breast milk to varying degrees. So psychiatric medications are transferred into the breast milk when decided whether to breastfeed while taking antipsychotic medications depends on you want to consider the fetus age. If the infant is a premature, infants are more vulnerable because they are young. I mean, they are small because they are premature. Infant health, you have to consider the infant health. You have to consider maternal psychiatric stability. You have to consider a relative infant exposure. You have to consider medication half-life. You have to consider clinical necessity. If it's necessary to take this medication, if it's necessary for the pregnant mother to have this medication, or feeding mothers to take this medication. Common breastfeeding considerations are left. Often considered one of the preferable antipsychotic medication. Zoloft is preferable antidepressant, not antipsychotic, antidepressant medication during the breastfeeding because infant blood concentration are typically very low. Zoloft is very low in breast milk. Zoloft concentration in breast milk is low and often considered one of the preferable antidepressant medication during the breastfeeding because infant blood concentration are typically very low. Paroxetine also associated with low infant exposure and is commonly considered compatible with breastfeeding. Fluoxetine has a long half-life. Fluoxetine has a long half-life and may increase the infant exposure. Monitor the infant for irritability, poor feeding, low weight gain. Lithium pass into breast milk and clinically meaningful for amount. So it is passed into the breastfeeding and its concentration is higher. Breastfeeding may be possible in carefully selected cases with coordination with pediatric monitoring of the fetus blood lithium level. So when the mother is taking the lithium, you are not mother who is feeding the infant. You are not only you want to assist both the mother and the fetus breastfeeding level. Lithium level in the both mother blood and infant blood. Okay. Lactation transfers into breast milk. You want to monitor the fetus for sedation, rash, feeding difficulty, and poor weight gain. If it's necessary for the mother to have lithium or lamartine, you want to assist the fetus, both the fetus and the mother blood level of these medications, so you know how to adjust the level, and you want to prevent the toxicity for both the mother and the baby. Antipsychotic medications. Many second-generation antipsychotic medications are compatible with breastfeeding but monitor in infants for excessive sedation, feeding problems, poor weight gain, and developmental concerns. Non-psychiatric treatment. Non-pharmacology treatments include evidence-based psychotherapy remains the essential. First-line psychotherapy include cognitive behavior therapy, interpersonal psychotherapy, behavior activation, supportive psychotherapy, family therapy when indicated. Lifestyle interventions include sleep hygiene, exercise as a medical appropriate, nutrition, social support, stress reduction for the mother, substance use counseling. Postpartum psychiatric disorders include the postpartum blue. What is the postpartum blue? Postpartum blue onset is the several days after the birth. It peaks the day 3 to day 5, and it lasts 2 weeks. Symptoms include tearfulness, emotional liability, irritability, fatigue. Management include reassuring the mother and supportive. Postpartum depression typically is within the first year after the delivery of the baby. Symptoms include persistent sadness, guilt, sleep disturbance, impaired boundary, suicidal ideation, and treatment include psychiatric therapy, antidepressant medication when indicated, or both. Postpartum psychiatric include psychiatric emergency, usually delivered within the first 2 weeks of postpartum. And these include delusion, hallucination, severe insomnia, mania, confusion. Those are the psychiatric emergency after delivery. They include Psychiatric emergency after postpartum psychiatric emergency include the delusion, hallucination, severe insomnia, mania, confusion, disorganized thought and behavior, rapid mood fluctuation. Risk is established. Risk is especially high in individuals with bipolar disorder or prior episode of postpartum psychosis. Requires immediate psychiatric evaluation. Hospitalization often involuntary if the safety is compromised. Mood stabilizer and antipsychotic medication consider of EKG, electroconvulsive therapy in severe or treatment-resistant cases. You want to educate the patient about the psychiatric depression and psychosis that could happen in the pregnancy or after the pregnancy. Teach the patient to never stop their psychiatric medication without consulting the prescriber. Attend a regular prenatal psychiatric follow-up visit. You want to educate to report mood changes promptly. Maintain adequate sleep and nutrition. Avoid alcohol and illicit drugs that can affect the mental health of the mother and the babies, the infant, fetus. Develop a postpartum support plan before the delivery. Learn the warning sign of a postpartum depression and psychosis. Ensure a family member know when and how to seek emergency help. Always weigh the risk of untreated psychiatric illness against the potential risk of medication exposure for the fetus. Bipolar disorder carry a particular high risk of a relapse during the pregnancy, especially after the delivery. Psychiatric changes during the pregnancy often require medication dose adjustment and with assessment postpartum. Zoloft is the commonly preferred antidepressant medication for patients who are breastfeeding due to a low infant exposure. Avoid fulbrate during the pregnancy where the possible cause of abnormality. It has a higher therapeutic potential. It has a higher risk for the developing infant fetus. Postpartum psychosis is the psychiatric emergency require immediate interventionist collaborate care among psychiatric, obstetrics, primary care, and pediatric is essential for optimizing outcomes.